Hi, everyone, and welcome to the Truth Care. I am Marlena,
And I'm Ashley.
and we have two special guests, Bobby and Cindy, and they are joining us so that we can chat a little bit about hospice and what it means to get on hospice and debunking the myth that hospice is only for people at the very end stages of life. Bobby, Cindy, why don't you tell us all a little bit about yourselves?
Sure. I'll go first. My name's Bobby Campbell. I've been with Moments for over 7 years. I cover the Southwest Metro, and my role as an executive hospice care consultant is to meet with different facilities, accounts, and places to let them know about our services, and then also to meet with families when it's time to bring their loved ones onto service and educate them about the hospice benefit.
And I'm Cindy Crawford. I'm actually a registered nurse, been a nurse for 34 years. My background in nursing starts with oncology, bone marrow transplant, and it's really there that hospice was being opened up to me in a different setting, different light. I was an admissions director where I created hospice suites for long-term care and then got recruited to become a hospice case manager. So did that for many years. Also did general inpatient hospice at the U of M hospital. So general inpatient being the highest level of hospice care with probably some of the most rare complex cases. Then now here with Moments and loving this role as a hospice care consultant.
I feel very blessed to have such experts here on the Care Truth. And we're definitely going to be debunking that myth
Mm,
because the reality is hospice is not about giving up. It's
mm.
about improving the quality of life, providing comfort, and allowing people to live as fully as possible in their final days. So, Cindy, I love your philosophy. I was looking at your LinkedIn profile a little bit about welcoming people with a warm cup of coffee and just having that authentic conversation. We're all at the Care Truth about keeping conversations real. We want to make sure that we're respecting everyone's journey, that we are empowering people with decisions, having those authentic conversations, but keeping them lighthearted at the same time. So help me understand a little bit about how people even start a hospice journey.
Actually, I think there's three very important components to starting the hospice journey. And it's really where I learned, excuse me, through experience sitting with oncology patients in a hospital setting. And what I picked up during those 5 years, there's three things people are looking for. First of all, they're looking for trust. So they're looking for a conversation, as you talked about, we want to empower people in this journey, but they're looking for someone that they can trust. They're looking for truth. So many patients would say to me, can you please come in and sit on my bed? Because there's nobody I can talk to about this. I'm newly diagnosed pancreatic cancer. I have 6 weeks to live. My family doesn't want to hear this. Nobody really wants to hear how I feel. So I learned that people really want to talk and truthfully, openly, like you just said, Marlena. And the third one was really about time. We need time. And I realized in the hospital setting, I just didn't have the time to sit. So hospice allows those three things. So opening up the conversation, a lot of people have what I tell them is their intuition, and to really listen to that. So it doesn't always start with a provider, but it starts right here. I wonder. And it's when in that wonderment to start asking questions. And Bobby and I, this is why we love doing what we do, because we love to show up for people and give them the time to talk through.
Yeah, I love that. Bobby, with you, I would say the biggest myth that I hear, being in the sales role is that most families believe, kind of like what Marlena had mentioned in the beginning, is that families think that it means that it's just the end, that it could be a matter of days. Can you help us understand why that's not necessarily true?
Sure. And that is probably the hardest thing that we come up with in all of our conversations because everybody feels that hospice is that, kind of a four-letter word that means that mom's dying tomorrow. And it's really just taking that time to educate them that hospice, when we're coming in, it just means that we're adding more care, we're adding more love, more eyes on mom, and just focusing. A lot of people think that it's the end thing that you can do, but it's just another form of treatment that a family can take. And we've seen people graduate. We've seen a lot of good things. People get better. All that added support can make a huge difference, and really kind of spending that time with that family and letting them know all that because they don't know what they don't know until we have that time to sit down with them and talk with them.
Right. So
Yeah,
Sorry, Ashley, I haven't heard graduate hospice. What does that mean? How do they determine if someone's graduating off a hospice?
Sure. I'll let Cindy take care of that. She's the RN.
Medicare has regulations, right? They're the payers, so they write the rules. We follow their regulations. And so statistically, about 16 to 17% will no longer meet criteria. And so what I try to tell families is, hospice is a holistic approach to care. So when you're getting your spiritual needs met, your emotional, mental needs met, and holistically your symptoms are being addressed, not just through medications, people can have this upward trend. And it's to be expected in hospice where people actually do better. But if you continue to do this upward trend, then Medicare will say, like, hey, you're no longer meeting a life-limiting illness. And then we look and set a plan in place for a live discharge. I've had a lady, I think she was 100 years old. She came in very compromised, really looked end of life, wasn't eating, bedbound. And 6 months later, she was singing hymns in the day room. So she was a live discharge at 100 years old, and I think she lived to 102. So age is not a factor.
Got it. And so if someone graduates off hospice, are they eligible to go back on hospice again later if they start qualifying again?
Absolutely. So nobody's ever penalized. Medicare does set up this benefit period. It's a 6-month benefit period. So when I do education around a hospice consult, most people who have had experience with hospice will say, yeah, I had a loved one and it was days. So the first thing I do is start showing with my hands, like it's not this type of benefit, it's this type. And then you have this aha moment. So if somebody's utilized, depending on how much time, so Medicare says first, you have a 6-month benefit period. And then after that, there's 60-day recertification period. So it's extended. So if they've used up the 6 month, it requires like a face-to-face from the hospice medical provider to show that this person is definitely terminal and appropriate for hospice, but you're not penalized. You just don't ever get a repeat of that 6-month benefit, if that makes sense.
Yeah, so after the first 6 months, they have to keep requalifying every
Yeah.
60 days. Yeah,
Yeah.
we had one little gal who lived with us. We called her the Energizer Bunny. She had at least 9 lives, and she lived on hospice for close to 2 years. And we'd see her like declining, and we'd call her husband in and be like, this is it. Where she's contracting, she's modeling, and then she'd bounce back. And then she'd be with us for a while, and she just always had just enough of a decline that she could stay on. But yeah, she was adorable. We miss her very much.
Mhm.
So, what are a couple of indicators that someone's appropriate for hospice to start this conversation?
Yeah, actually, there's quite a few, Marlena. And the research shows going back, somebody typically in their last year of life, the indicators start. So when I do the education, I teach people like, hey, your brain is kind of your microchip, and it detects the changes in your body and starts a process in place. So one of the first things typically that we see, not all disease process, is weight loss. And so understanding, if families understand there's a reason behind this, the brain's detecting these changes, starts reducing the gastric blood flow. So understanding like they don't have the blood flow to start breaking down the food. So we start to see Medicare will say 10% weight loss in 6 months or a 7.5% in 3 months. But other things are beginning to happen and start to shift. The immune system is not as strong as it used to be, right? So what do you start to see? UTIs, repeat UTIs. And so families will say, oh, they have another UTI. And I said, well, is it another one? Or was it that their body never really responded to the antibiotic and it maybe suppressed the symptoms and it's just receding? And then that begins to make sense. So, and weakness, because now they're not eating, you start seeing falls, trips to the ED, rehospitalizations, pneumonias, because what happens is it takes the whole brain to swallow correctly. And we lose that ability to swallow. Now we have aspiration. And they'll start to tell you, like, it's really hard to swallow, or we're starting to crush pills, things like that. So those are probably some of the main factors that you'll start to see is your infections, hospitalizations, weight loss, fatigue, increased daytime sleepiness. Is there anything else you can think of, Bobby?
Kind of, you see them withdrawing a little bit more from doing activities,
Yeah.
just all kinds of, like she said, there's so many different signs to look for, and each disease has a little bit different thing to be watching for too.
Heart
Yeah.
failure, you'll see weight gain, not the weight loss, because they're no longer responding to diuretics. And I think it's important to note that people that come into hospice with heart failure live 81 days longer.
Good to know. I love that.
Mm.
So you mentioned the Medicare word and that they have qualifiers. So what are some of those qualifiers that allow someone to be hospice eligible?
Yeah, so there's a lot of different, depending where the disease is. So Medicare goes into lab values, they're very specific. So instead of going to teach families some of those very clinical things, I go to some of the things like activities of daily living. Are you starting to see an increase when you look at the 6 areas of activities of daily living? Are they needing to have more? Are they more dependent? Do they need help getting dressed, getting showered? Are they incontinent of bowel and bladder? Those type of things. So when you start to see somebody needing more help, the other scale, which I think is easier for families to understand, less clinical versus like here's the lab values, is the palliative performance scale. And that scale goes from 0 to 100. 100 is fully functional, taking care of yourself. 0 is death. And then I tell people I'm at about a 90%.
Yeah.
Because if my sons want to go to the grocery store, I'll say, go ahead. And what that does is I'm starting to conserve energy, right? Conserving energy. But when you get down to that 40 to 50%, they're doing half of what they normally did. So think of that. They're doing half of what they normally did, and now they're dependent. So those are two cues, really. The palliative performance scale, activities of daily living. Those are some of the signs that we look for that families can understand, because I think it's important to empower, to educate like we're doing today. So families can go, oh, I see these changes. And it's interesting because I have hundreds of consults under my belt. When you provide this education, you can actually feel the anxiety decrease
Yep.
because now they're being empowered with knowledge. Does that answer your question?
Yeah, for sure.
Yeah, so it sounds like it's not just for the last few days or weeks that we've kind of talked about. It's really there to support the family and the patient earlier in the journey, the better, right? Because that will help alleviate the symptoms and manage some of the pain and things like that earlier on. Is that right, Bobby? Am I understanding
Yeah,
that?
and it also helps add support for not just that patient, but helps add support for that family too. We kind of help wrap our arms around them to make sure that they're going through this journey and helping answer questions for them and just making sure we're there for them both spiritually and whatever needs they may have as well.
You know,
Absolutely.
just to go back, Marlena, because there are these one-off cases, and I think of a 20-year-old that I took care of in my home that was in hospice, and she had a rare disorder. She had intestinal failure. So that's not one of the heart failure, end-stage renal failure, COPD type cancer that we can go to. There are no guidelines around intestinal failures. You have to look at some of the outside the box things. And then she was told there was nothing more they could do for her. And so it really, Ashley, Marlene, it comes down to, okay, there's nothing more you can do to treat my terminal illness. Then I want to live my days the best that I can. And that's really what hospice embraces, is about living the best that you can with whatever days you have left.
I
So
love
what therapies do you guys do or add on that can help
Mhm.
alleviate some of those pain?
Yeah, we can add music therapy, massage therapy, and some pet therapy as well, if those are things that they'd like. Let's say they're currently on doing some therapies now where they're just doing some range of motion things. We can help out with things like that too. So they wouldn't be doing therapy in a building anymore, but we would be helping do some of those things where they're at, where they call home.
That's
Perfect.
awesome. And all these gifts, what all does hospice cover? You mentioned therapies, you mentioned support. What all does hospice cover and who pays for hospice?
Sure. So Medicare is the hospice benefit, but a lot of other private insurances also cover hospice. Most of them follow the same guidelines as Medicare. There are a few that are a little bit more challenging to work with, but we're usually pretty flexible as much as we can be. Hospice covers any of the equipment that is required, hospital bed, wheelchair, lifts, things like that. We also cover any of the medications that are part of their hospice diagnosis. And then we would also cover any supplies. So if they need incontinence supplies, wipes, gloves, all those things, those are all covered by that benefit. So pretty nice. Usually there's no cost to the family. I've only seen a few times where maybe it was a private insurance and they didn't have their deductible met. But other than that, it's almost always covered. And if we do have families, we have seen this in the past too, that don't have any coverage, need hospice. We do have our nonprofit arm of our organization too, that does pro bono cases for people too.
That's amazing. I love that. I love that it's not just one avenue to get that support. That's fantastic. Thank you.
You're welcome.
Yeah. And so they don't have to be necessarily in the hospital or in a TCU. They can be at home receiving these services, correct?
Wherever they call home. Hospice can't be provided by us in a hospital setting just because of the billing situation, but wherever they call home, whenever they leave the hospital, we're there to help support them all the way to the end. And then 13 months longer, we're there for bereavement support for the family.
Awesome. And how do you even begin to have the conversation? I feel like a lot of families don't even know how to begin the process. What would be some recommendations for you?
That's a really good question, Ashley, because it's really where I would say the bulk of people are, like, where do we start? So I always go back to the trust. Let's just start at the beginning. Let's learn something about you, your journey, what's taken you to this point, doing a lot of active listening. Tell us about you and the questions you have, fear that you have. I think of one hospice consult I went to, and I was basically told, don't you dare talk about hospice. Don't talk about death and dying. She's totally afraid. Don't mention those words. So I spent about 45 minutes just getting to know this woman, her story, her life history, building that trust. And then at the end of about 45 minutes, I said to her, I said, I think you know who I am and why I'm here. And I just open, honest conversation. Is there anything on that we've missed that we haven't covered that needs to get on the table today? And she goes, I want to talk about death and dying. I want to talk about hospice. So if we just take the time to be there present up front and people feel like you're safe and we can have these conversations. So just understanding these conversations take time and we often don't get there on day one.
No, we got to find out where they are in their journey and what their goals are. And we need to come in and see if we can help wrap ourselves around them and support them.
Absolutely.
That's fantastic. And I think so often everyone relates to stories, right? Tell me a time when, you went in and didn't think that hospice was that the family was going to work out. And then all of a sudden it did. Everyone clicked together. And then tell me a time when hospice couldn't get involved because they weren't quite ready. And what does that look like?
So the first scenario is a personal one, Marlena, and I'll just take a minute. It was my dad. And so my dad had this long cardiac history, very lengthy. In his 50s, he would end up in ICU from panic disorder. He was so afraid of death and dying that they thought he was having a heart attack, only to find it was anxiety around death and dying. So I was like, take note to self, like, dad's not going to die if this is how it is in his 50s. However, he had a procedure, TAVR procedure, and he said to me, like, hey, if I have the side effect or the risk of this, which was a stroke, he goes, don't you dare prolong my life. And I was shocked that he would say that. Well, that's what happened. He had a stroke during the procedure. And to describe my dad, I will use respectfully words like belligerent and cantankerous. And so I thought, oh, God bless this hospice team. It's got to go in and take care of my dad because he was so resistant. And I just want to say, he was in hospice for 15 months. He had heart failure. They extended his life with medication adjustments. A lot of people don't know. They have this idea that we strip medications away. They're actually very aggressive with managing symptoms. But the last week of my dad's life, it was the most peaceful. And I thought, you know what? This is the work collectively of the hospice team, including the home health aide, that had to win his trust, build the trust. To die with very limited medications when he had this history early on in his life. The important part of this is you don't get this type of experience if you're coming into hospice 1 week, 2 week. He needed that 15-month time with his hospice team. And I'll never forget walking into his apartment shortly after he admitted to hospice. He was in a wheelchair, but his blue eyes were lit up and he was smiling. And I'm grieving. I'm the adult daughter grieving all of these changes. And so I looked at him and I said, okay, Dad, what is up? And he was smiling and he said, I am living like a king. And I said, what? You're living like a king? And he goes, music therapy was just here. My dad was a singer in the Naval Choir and High School Musicals. I grew up listening to him sing. That was so like enlivening for him to experience music therapy personally. And he goes, I have all of these people coming to see just me. And so for him, living like a king in hospice.
I love that. Bobby, what's one of your favorite stories and why you love being in hospice?
Oh, dear Lord.
Oh,
I got way too many.
yes, he does.
How long is this podcast? Uh, I'll use my favorite one, and it kind of goes back to us talking about graduation earlier. Went to go meet this sweet little old lady. She was almost 103. Her birthday was coming up in about 2 weeks from when I met with the family. Met with her niece and nephew, and they said their goal for her was just to make it to her 103rd birthday. Well, she made it to her 103rd birthday, made it to her 104th birthday, graduated off of hospice because she got better, and then came on just before her 105th and passed away shortly after that. But it was one of those that kind of surprised me because when I first walked in and saw her, I didn't think she was going to make it to her 103rd birthday, but it was awesome. And my favorite thing is we asked her what the secret to that long life was, and she said, I stayed away from boys. She was never married and never had any kids, so she stayed away from boys.
I can see where the stress level would be a lot less with
Yeah,
both
yeah.
of those things.
Yeah. And then I've got one more favorite story I love to tell too. I usually get a bunch of flowers from an organization called Bluebirds and Blooms. And they had me going down. I went into a facility, bringing them to hospice patients and other residents. And I was bringing some into this sweet little lady. And the aide that was going in with me said, well, she hasn't talked. She wasn't been able to talk for over 6 months or 6 or 7 months. So we walked in and she sat up in her bed. She held the flowers, smelled them, and said, these are just beautiful. It was such a cool moment. The aide started crying. She got to then call the family and say that mom spoke again for the first time in months. It was just one of those neat things. It kind of ties back to a program that we have called Namaste Care, where we're doing those sensory based things, where we're just trying to touch their senses and do special things for them too. That just kind of woke her up a little bit. It was pretty awesome.
I love that. That gave me chills. That's fantastic. Well, I definitely feel that we did a great job debunking the myth that hospice is just for the final days of someone's life. So thank you so much, Bobby and Cindy. Any other parting things you want to make sure our listeners know about before we end?
I would just say if anybody has questions about hospice, please reach out to us. We're glad to sit and talk with anybody, even if they don't choose our agency. We just want people to know about the benefit and take advantage of it because they've earned it, they deserve it.
And I'll just add too, I love the idea of having a cup of coffee and a conversation. Let's start stripping the fear away. And so I usually intro by saying that let's strip the fear away and let's just have a conversation and provide some education. And boy, does that change the energy in the room.
Yeah, perfect. And then just to recap, just to make sure that our listeners are aware, hospice is covered by Medicare or Medicaid in most insurance plans, correct?
Correct.
And then don't wait. Just if
Mhm.
you have some of the key indicators, the sooner you start, the better the process will be in most cases.
Absolutely. Yes.
All right.
Well, thank you everyone so much for joining the Truth Care. We appreciate you taking the time and learning a little bit more about hospice. Hopefully this conversation cleared things up for you and you have a better understanding. If you found this episode helpful, please like, share, tell others about it. We are desperately trying to increase our following, and we really appreciate Bobby and Cindy for taking some time with us and all of our listeners. If you have any other questions, what's the best way for them to get a hold of you two?
You can just call 1-800-MOMENTS, or we can share our information if you'd like as well. They can always reach out to us directly.
Perfect. We will have in the comments section ways for you to get a hold of Bobby and Cindy. And if you have any suggestions on future topics or other questions that the Truth Care can answer, please email us at thecaretruth.com. I'm sorry, that's wrong. thecaretruth@gmail.com. Thank you all so much. Have a great day, and we'll talk to you soon. Bye.
Thank you.